Hello, my name is Marcel Viege. I work for the national mental health charity Mind. I manage a team called Diverse Minds, which is a policy and campaigns team that focuses on issues of race, ethnicity and mental health. Going forward, now that the Count Me In census has now been ended, with the ending of delivering race equality, the sort of next focus is looking at what's called the minimum data set, which is effectively a kind of wider collection of information around the use of health services, and specifically our interest is going to be within the mental health system, within mental health services. Now, the information, the data that's collected as part of the minimum data set is a lot more comprehensive. It's not just a one-day snapshot. It's a kind of ongoing, rolling piece of work, if you like, which continually draws in data. And the idea is to take the areas that were examined within the Count Me In census and ensure that that they're included, if you like, into the minimum data set. So it won't be like a direct transference, but what you do is you look at the sorts of areas that Count Me In looked at, and you make sure that the minimum data set is covering those, but it's doing it in a way that is a lot more comprehensive. It's a lot more detailed and a lot more thorough. Having had discussions with members in the mental health team of the Care Quality Commission, it seems that there are some quite concerted efforts to make sure that the race equality data, or the race ethnicity data, however you want to term it, is actually a significant part of the minimum data set, and it will make a difference in terms of the data being more comprehensive, being richer, and therefore being more useful, both in terms of people understanding what's going on within mental health services and how they're affecting people from different ethnic groups in different ways. That's useful for people like me who campaign in this area, but it's also useful for people who commission services, because they can get quite a detailed picture of what's happening both nationally and potentially in their area. And so it's a useful way of them kind of, if you like, weighting services in a particular way that matches matches more closely the local need. With the minimum data set, given that it is a more comprehensive, more detailed piece of research, it inevitably becomes a bit more complex. And certainly the messages that I've had from Care Quality Commission is that they're very much aware of this need to make sure that there is a kind of communication a communication aspect to it. This communication is thought about, and there's a way of capturing it and delivering it in a way that's going to be accessible and usable and able to be used, not just by professionals and by people who are very well versed in understanding detailed sort of data and figures, but the general public more widely. And certainly, I think that in terms of looking at the quality of the data, making sure that the data actually does what it's supposed to do and it captures the sorts of things it needs to capture. I think there is a role for people who work broadly within the kind of race and mental health world, if you like. There are various academics and people who do research who would have that knowledge, who I think it's useful as to kind of bring them in and as a kind of reference source. I'm talking in terms of CQC, bringing them in as a reference source to kind of help them develop this. As I said, it's been accepted by CQC, and it's something that they're very much interested in doing. But I think also it will be useful, or it will be useful for CQC to actually draw in wider stakeholder networks of race equality, people who work in the field of race equality, to think about that communication question and to look at how best it can be packaged up and delivered out to the public more widely.